and so, my next piece is on liver transplant for a PFIC. And so the first part was all non-transplant surgery in patients that have relatively preserved liver function. Liver transplant for PFIC really is reserved for patients who have end-stage liver disease. And so their disease has progressed, their liver disease has progressed to where they have cirrhosis, or they have medically and surgically intractable pruritus, or they've developed evidence of hepatocellular carcinoma. And so the post-transplant concerns between the different types of PFIC are different. We'll talk about that tomorrow. It's kind of a relatively dense subject, but I think that it's important to realize that you can't clump all PFIC into one. But I think that overall, I'm going to talk right now about kind of transplant in general for these diseases. So what's involved in a liver transplant? I can give you a brief introduction. It requires like a day-long teaching seminar for our patients, but what's involved? Well, literally you remove someone's liver, which is the largest solid organ in your body, and you take someone else's liver out, and whether the person is brain dead or a living donor, you take that liver out, you put it on ice, and then you put another person's liver into a person. And so it's not a small undertaking. It's a major surgery. It's one of the the largest surgeries that you can do. And these are kind of cartoons of the types of liver transplants. The one on the left is a whole liver, and so it's a liver transplant, say from an adult to an adult or a child to a child. The one on the right is a segment liver transplant, and so if you look at the liver on the left-hand side of the screen, the far left portion of the liver represents the entire piece of the liver that would be put in. And this is obviously a, adult to say a child liver transplant. This is what it looks like in reality. And so, you can see this is not a small operation. These are not small incisions. And it's something that kind of really needs to be taken into account when you're talking to somebody about liver transplant. And again, the centers that do liver transplant in children are very well versed at teaching families and even the children about the surgery and about the medical complications of the surgery. But I think it's I think this picture is great to kind of say, okay, well, indeed this is not a small surgery. And so, simple question one, where do you get a liver? And so there's two sources really. One of them is deceased donors, and so these are patients that are brain dead, and so they've become brain dead from head trauma or from a stroke, and you can, or any variety of reasons. But I think that you can say, well, the livers could be a pediatric size match, and so you could use a whole liver from a child into a child if they're about the same size, or if it's an adult that is deceased, you could take a portion of their liver and put the small left portion of their liver into a child and put the right side of their liver into an adult. And so those are called technical variant grafts. Likewise, if you had somebody that was willing to donate and was otherwise healthy, you can do a living donor, and it can be adult to adult, it can be adult to child, and the person could be related, or they could be unrelated, or it could even be altruistic. And so we have people that want to give pieces of their liver to children or even to adults, and the recipients don't even know them, and so there does not need to be any sort of blood relation or even friend. It can be essentially an altruistic donor. Another population of patients that can give livers is what called a domino donor. And so there are specific genetic diseases that do not affect the liver, but affect the entire body. There's a disease called maple syrup urine disease that affects the body, does not affect the liver, and it is cured by liver transplant. And so you can take a liver from somebody that does not have maple syrup urine disease, put their liver into someone with maple syrup urine disease, and then take the liver that you've taken out of the person with maple syrup urine disease and put it into another person who has another disease. And so it's indeed, we've done a transplant for that involved a domino donor from a patient with maple syrup urine disease to somebody that had PFIC. And so indeed, it's not something that is unheard of, and so it's another source of donor livers. When you're talking about transplant, though, you really have to weigh out the risks and the benefits. And so, when you look at the benefits of transplant, really, you have to think about, well, what's the risk of not having a transplant? And so, on the left-hand side, you have to look at what if we continue to just do medical management. You have to look at the natural history of the disease, and what is the likelihood that this person's liver is going to get worse, or what would happen if they were a cirrhotic and they had liver failure. And so patients that have PFIC, really would only be considered for transplant when they started to have liver failure. Also, if you just continue with medical management, what's the risk of cancer? What's the quality of life of a patient that has intractable pruritus? And again, what is the mortality of medical management? How many patients that have PFIC 1 or PFIC 2, say in 15 or 20 years, are still alive? And so that's kind of the, if you didn't do a transplant, you think about the left-hand side. When you talk about liver transplant, you have to think about early issues after liver transplant. So are there surgical complications? What are they? What about medical complications? And then you have to think about late complications, because a liver transplant is not something that goes away. You have a liver transplant for life, and so there's only it's only one time, but it's something that lasts for your entire life. You need to be on medications for your entire life that you have to take, which means that you have to be adherent with those medications. And then there's disease-specific issues, and then again, we'll talk about that a little bit tomorrow. But these are kind of the risks and benefits associated with liver transplant for kind of chronic liver disease. When you talk about transplant, the early things, you have to think about logistics. And so, if you live away from a pediatric liver transplant center, you have to go to a liver transplant center. If you have a liver transplant, you're going to stay on average about 18 to 21 days. And so, it's a prolonged hospitalization. It's about 3 months of at least weekly visits. And so if you live far away from a pediatric liver transplant center, it's a big kind of commitment, and it's a big disruption where you'd have to be in a place where you could or stay nearby your pediatric liver transplant center. And again, there's multiple medications, and so there's no doubt that patients after liver transplant are on more medications than patients that have PFIC. And so the early medical complications, you talk about complications of the medicines that we use to prevent rejection. And so these oftentimes cause issues with hypertension. It can cause renal issues. It can cause issues with seizures if the levels are very high. It can cause transient diabetes. These medications can also frequently cause electrolyte disturbances. And again, these are all things that are early after transplant, but something that kind of has to enter into the risk and benefit. The other thing you have to think about are, pre-existing medical issues. You have to think about pain management and nutrition. Patients that have PFIC 1, certainly, and even, the other types of PFIC have issues with nutrition. And so to undergo major surgery does require a lot of nutrition to heal. And it is a concern that we have both before and after transplant. Rejection is commonly thought about when you have a liver transplant, but it's not something in reality that is a huge kind of graft or life-threatening problem. And so rejection happens about 30% of the time after a liver transplant, and they're correctable by changing medications around. Sometimes patients require rehospitalization. The risk is lifelong, but the risk of rejection is highest in the first 6 months after transplant. And so when patients reject, they oftentimes get readmitted to the hospital. They get put on higher doses of immunosuppressive drugs, and then they're followed closely afterwards. But it's not unlike heart transplant, where rejection can really lead to the death of the patient and death of the organ. Liver transplant rejection is a much different process. What about surgical complications? Well, we're not perfect, right? And so again, it's not a small operation. And so any one of the things that we do can have issues along with it. And so the routine things that we think about after transplant, abdominal closure And so, I think that when you take a piece of an adult liver and put it into a small child, or even when you take a child's liver and put it into another child, they may not be exactly size matched. And so some patients require delayed closure, and so they require operations after the transplant to close the belly. Um, every time you do surgery, you worry about infections, you worry about bleeding. Um, Liver transplant has come a long way in the past 20 years, and we oftentimes do transplants without needing any blood. But there is a risk of bleeding, and it happens about 1 to 5% of the time after a transplant. Infections, bacterial infections, bile is not a clean substance, and when you do a liver transplant for a period of time, there's bile leaking out of the liver into the abdomen, and so that it's not a clean case. Liver infections do occur. Fortunately, it's not often, and so only a few percent of the patients that have a liver transplant get any type of bacterial infection. But it is something, again, to be concerned about. It's something to think about.